Hi, everyone. It's so great to see everyone on here tonight. We do want to thank everyone from across campus, as well as throughout the state of Alabama, for joining the seminar with us tonight. I'm Vicki. The seminar is hosted by the Maternal and Child Health Student Association at UAB. If you're not familiar with that, it is a organization that's on the campus that consists of undergraduate and graduate students who have a very high interest in maternal and child health. If you are interested in learning a little more about the group, please just check out our page on the UAB Engage. It's NCHSA Engage page. We do want to let everyone know that we are recording the seminar, and as soon as that is available, we will be able to provide that to you so you can share it with your friends or colleagues or anyone else who you think may be of interest. And a little side note on the recording, if you have any questions and you ask Dr. Matthew, he will be repeating the questions back just so that we have permission to record that. So it is my great pleasure and honor to be able to introduce Dr. Matthew Moore. He is a wonderful person as well as professional. He is a lifelong learner. He who really hopes to help bridge that gap between public health as well as clinical practice, especially as it relates to vulnerable populations such as mamas and babies. He received his bachelor's degree in nutrition dietetics in 2016 from Auburn University. And as much as it pains me to say it, I will say War Eagle just because I respect Dr. Moore. He received his Master of Public Health in 2017, and he received his Doctor of Public Health in 2020 in Maternal and Child Health Policy and Leadership, and those were through the UAB School of Public Health. So I will proudly say go Blazers on that one. His research interests have been geared towards maternal and infant morbidity and mortality through through perinatal health research, public health technical assistance, as well as clinical quality improvement initiatives. He is currently pursuing his Doctor of Education at the UAB Heersink School of Medicine with anticipated graduation date of 2024, and we just know and expect so much of him once he graduates. So please, everyone, help me welcome Dr. Matthew Moore to tonight's seminar.
Thank you, Vicki, so much, and thank you for that War Eagle. That was definitely worth the attendance today. So good afternoon, good evening, wherever you are. Thanks for everyone attending this talk sponsored by MCHSA. As a past president of the group, I'm honored to be back to give this talk on hypertension in pregnancy from a public health perspective. I plan to stick to as close to 30 minutes as possible so that we have time for questions and discussion at the end. First, I'd like to give a little background, maybe not on myself, but since Vicki did a great job on that, but mainly emphasizing that I have been on quite a circuitous journey throughout my education. Too much if you ask me, but I'm always learning. Today's topic is pretty complex, and so I hope we can all continue to learn together as we work towards better health for all mothers and babies. Now, I've had my nose in many textbooks during medical school the past couple of years. So this has certainly given me a fresh angle to view some of these important public health topics that I was exposed to during graduate school. However, there's a lot of things occurring in our state and our country around hypertension in pregnancy and maternal mortality and morbidity. So there's no way I can cover everything, and I'm certainly not up to date on everything. So I just want you to know this talk is a kind of a broad overview of hypertension in pregnancy from a public health perspective. So with that, I just have two goals for today's talk. The first is to understand the significance of hypertensive disorders of pregnancy, including their impact on maternal and child health. And then recognize the complexity of the surveillance, diagnosis, and management and outcomes of hypertensive disorders of pregnancy. Some of you may be experts in this area while others are still learning some of the lingo, and that is okay. Hopefully by the end of this presentation, we can all agree that the topic is both significant and complex. With that being said, we're going to hit a lot of aspects, and so buckle up, please. A brief outline of today's talk. I'm going to start with some definitions of terms that I'll be using. Then I'll give an overview of epidemiology of hypertensive disorders of pregnancy. Next, we'll look at Alabama specifically through some research I conducted as part of my dissertation. And then lastly, and most importantly, I might say, we'll review some public health strategies that are addressing hypertensive disorders of pregnancy at various systems levels. So with that, let's start off with some definitions. So from here on out, I'll use HDP instead of hypertensive disorders of pregnancy. This is quite a heterogeneous term that I'll break down in the next slide. The Society for Maternal Fetal Medicine defines severe maternal morbidity, or SMM, as unintended outcomes of the process of labor and delivery that result in significant short-term and long-term consequences to a woman's health. So that's SMM, how I'll refer to it. And then lastly, whenever Medicaid will be discussed, I like to remind everyone that Medicaid is the federal state partnership to provide healthcare coverage for individuals with a limited income. Medicare is the federal social program primarily for individuals 65 and older, and some individuals with disabilities or specific conditions like end-stage renal disease. So hypertensive disorders of pregnancy, HDP, is really a broad term that encompasses any form of hypertension or high blood pressure that occurs during pregnancy. The American College of Obstetricians and Gynecologists, or ACOG, divides this into 5 categories. First, chronic hypertension, which is something that exists before pregnancy or is diagnosed before 20 weeks gestation. Conversely, gestational hypertension and eclampsia began as a result of pregnancy. So preeclampsia is the most severe form of HDP and can occur before, during, or even after delivery. And if left untreated, often progresses to eclampsia, which is a life-threatening condition characterized by new onset seizures. Additionally, superimposed preeclampsia develops when a woman with chronic hypertension also develops features of preeclampsia. And lastly, postpartum hypertension, which is an informal classification, occurs after delivery and often after a woman is discharged from the hospital and can therefore be quite dangerous. Now, unless otherwise specified, I'm going to be referring to these categorizations in aggregate, but sometimes we'll get into the specifics of one classification over another. So now now that we have a handle on definitions, let's look at some of the burden of disease for HDP and related outcomes. So globally, estimates suggest that preeclampsia and eclampsia, which is that most severe form of HDP, affect 4.6% and 1.4% of pregnancies respectively. And you can see where they get this average on the map here. It's not every country, but it's a lot of countries. In the US, estimates from public health surveillance indicate that the prevalence of all kinds of HDP is somewhere between 6 and 8%, and it's increasing in recent years. In 2017, interestingly, new guidelines were put out by the American Heart Association and the American College of Cardiology that lowered the threshold for chronic hypertension from 140/90 millimeters of mercury systolic and diastolic to 130/80. However, the influence that this is going to have on HDP specifically is still being determined. However, one publication which applied this new criteria to a cohort of over 130 singleton pregnancies demonstrated that the increase in HDP would be from 10.3 to 28.1% in their cohort, so quite a substantial jump. However, in the US, the previously mentioned cutoff of 140/90 is still used for pregnant women. Now, SMM, as we discussed, is severe maternal morbidities. It's actually a composite of 21 diagnosable severe outcomes of pregnancy, things like eclampsia, acute renal failure, and myocardial infarction. Estimates from the CDC indicate that SMM has been increasing over the past 2 decades in the US, affecting over 15,000 women per year. While much of this increase is driven by blood transfusions, other SMM indications have increased by 20%. The cause of this overall increase is unclear, but evidence has pointed to things like older maternal age, increasing prevalence of obesity before pregnancy, greater burden of conditions like HDP, and also advancements in medical technology like in vitro fertilization. HTP is associated with SMM in a dose-response relationship, meaning that women with more severe forms of HTP actually have a higher risk of SMM than women with less severe forms. So it's an important relationship to understand from a research and public health perspective. Additionally, there are racial and ethnic disparities which are important to this discussion. So Black women have almost double the rate of SMM compared to white women. And this trend has persisted both over time, as you can see in that figure, and then also across age groups. You can see that Black women are at an increased risk compared to Hispanic and white women. Do note that these data are from Blue Cross and Blue Shield specifically, which is a private insurer, but that just goes to show that even in a quote wealthier cohort of individuals, there are still pretty stark contrast with racial and ethnic disparities. So when we think about the outcomes of HDP from a pregnancy perspective, there's kind of a balance between the maternal and neonatal outcomes. There are numerous adverse outcomes associated with HDP for the mother, including stroke, postpartum hemorrhage, and even death, as well as for the neonate, including stillbirth, growth restriction, and preterm birth. And therefore, decisions to induce labor or expectantly manage a pregnancy complicated by HDP have to weigh those differing risks and benefits. Either decreasing morbidity, mortality for the mother while increasing it for the neonate, or vice versa. Similarly, the use of antihypertensive medication in pregnancy is still debated because the competing risks and benefits of the mother and baby. The main concern with blood pressure meds is the theoretical risk of reduced blood flow to a developing neonate and poor growth in utero. And we'll discuss this a little bit more because there's been some recent developments with using medications during pregnancy. So lastly, in terms of epidemiology, we'll just touch on maternal mortality because HDP increases the risk of mortality in a woman who's pregnant. And the mortality rate in the US, maternal mortality ratio, to be exact, has been increasing in recent years. You can see that this orange line is the United States. The lines below it are all of our industrialized peers. So we are increasing in quite a way that others aren't. And HTP can be both directly and indirectly contributed to this, to the top 10 causes of maternal mortality in the US, which further justifies the importance for public health. When we look specifically here in Alabama, we see similar trends, and even worse, actually, the Alabama leads or is third in the nation in maternal mortality. And 70% of these deaths are deemed preventable after extensive reviews by a multidisciplinary team. So we have some work to do in Alabama. And while many of these deaths are driven by substance abuse in the postpartum period, I just want to stress that maternal health can't be restricted to just one time period or one disease process, but we really need to focus on treating the entire woman for the sake of both her and her baby. So I know that's a lot of data, a lot of numbers, but let's dive in a little bit more and look at Alabama specifically, since a lot of us are working in Alabama, are students in Alabama. So we'll look at some data that I actually used and produced during my dissertation a few years back. So first, as we discussed, Medicaid is the federal state partnership that provides insurance for people who have a lower income. They insure 60% of births in Alabama specifically. And the eligibility for pregnant women falls into 5 categories roughly. The first is MLIF, or Medicaid for Low-Income Families, which requires that recipients be a parent or caregiver with an income below 18% of the federal poverty level, which is pretty low. SOBRA, which stands for the 6th Omnibus Reconciliation Act coverage, requires that recipients are already pregnant and have a household income below 146% of the federal poverty level. Again, I want to emphasize that these women in particular may not have any insurance coverage before pregnancy, since pregnancy is why they became eligible at this more generous income requirement. CHIP stands for the Child Health Insurance Program. This is for individuals who are less than 19 years of age. They insure individuals who are not pregnant as well, but also coverage for individuals less than 19 who become pregnant can be covered under CHIP. Disability is kind of not a catch-all, but it's a heterogeneous group of individuals who qualify for generally supplemental security income or disability-related coverage. And then lastly, there's a category called non-citizen coverage, also known as emergency Medicaid, which requires that a woman's child qualify for Medicaid after being born. So it's not about the woman, but about the child that would be born. However, this form of Medicaid does not include prenatal or postpartum care. So with kind of that in mind, that there are different pathways to being insured under Medicaid in Alabama, let's look at some data that we looked at a few years ago with a team at UAB. So this was a cross-sectional secondary analysis of claims data using Alabama administrative claims from Medicaid. All deliveries with a claim year in 2017 were included, except those that were insured by non-citizen or emergency Medicaid. And the outcome we were looking at for this first study was having any HDP diagnosis. And these results are actually published in the Journal of Women's Health, as indicated below. So this study investigated multivariable relationships using mixed models, and we found similar demographic trends to existing literature. In our fully adjusted model, Black women had higher odds of HDP diagnosis, while Hispanic women had lower odds compared to white women. Additionally, older women or older age was associated with increasingly higher odds of HDP diagnosis compared to women ages 19 to 24. And then lastly, with women with comorbidities had higher odds of HDP diagnosis compared to women without these conditions. And we looked at a few: diabetes, gestational diabetes, obesity, and mental health conditions. In addition to demographic trends related to care also emerged. So women eligible for that SOBRA Medicaid who have unknown preconception insurance coverage actually had a higher odds of HDP diagnosis when we compare them to women eligible for MLIF, the majority of whom had preconception insurance coverage access. Also, women entering prenatal care in the second trimester actually had higher odds of having an HDP diagnosis compared to women entering in the first trimester. And then we investigated these trends further and calculated predicted probabilities of being diagnosed with HDP based on this trimester of prenatal care. So on the x-axis, we have the trimester of prenatal care entry, first, second, third, or no prenatal care. They just presented at delivery. And on the y-axis, we have median predicted probability, which is just the probability that any woman that fits these characteristics would be diagnosed with HDP. So the predicted probabilities of diagnosis were high, over 15% in the lowest risk age group. This is just looking at 19 to 24-year-olds because that's, quote, the healthiest range of pregnancy age-wise. And we really wanted to isolate the effects of other factors. So around over 15% of this group had a predicted probability in the first trimester. Women who entered prenatal care in the second trimester, indicated by this kind of upward trend line, had the highest probability for both SOBRA and MLIF. However, women with no prenatal care had the lowest predicted probability. And this is likely related to selection in our sample, evidenced by earlier entry into prenatal care for women with a diagnosis. But it's really hard to tell why this trend goes downward for women with no prenatal care at all. So you can see from this figure that women insured by SOBRA had higher median predicted probabilities than women insured by MLIF, which again, likely had preconception insurance coverage. I'll also note that there were racial and ethnic disparities with these outcomes that I don't have data today to present, but Black women in particular had an increase in the percentage point difference in having a predicted probability compared to white women. So another aspect of the research we did was looking at SMM diagnoses. It's a similar study design, but our outcome was different in this next study. So this table represents sociodemographic characteristics. We also examined comorbidities and care utilization factors. But these factors aren't presented here. However, we did use those as covariates to adjust the model as indicated in the footnote. So important results here. We saw that Black and Hispanic women had higher risk of SMM compared to white women, but this actually differed by whether they had an HDP diagnosis or not. Among women with an HDP diagnosis, Black women had a 40% increased risk of SMM compared to white women. And then among women without HDP diagnosis, in that far right column, we saw that Hispanic women had an increased risk of SMM compared to white women, almost 70% increased risk. Also, maternal age was significant among women with HDP diagnosis, but actually, I'm sorry, without HDP diagnosis, but actually not significant among those with HDP diagnosis. Also, we saw that sober Medicaid was associated with a lower risk of SMM, but that was only for women without an HDP diagnosis. And then lastly, community poverty, which we proxied by looking at the Medicaid enrollment proportion in a maternal residence county as low, mid, or high. This was associated with an increase in SMM, but only for women without HDP diagnosis. I know that's a lot of data about Alabama, so I'm just going to recap the highlights here because it's important to understand the implications for this in our state. So we saw that probabilities of HDP diagnosis were higher even among this lowest risk age group. Our estimates range from 8 to 18% prevalence of HDP, whereas the national average is around 6 to 8%. So HDP is higher in Alabama, especially among those with Medicaid. Also, we saw that HDP diagnosis was associated with differences in care, specifically with prenatal care entry among those with sober Medicaid in particular. We also saw that race and ethnicity modified these care disparities, but the trends were similar. But in particular for Black women, the disparity was greater compared to white women. Additionally, we observed that compared to white women, Black women had a higher risk of SMM among those with HDP, but Hispanic women had a lower risk, or a lower risk among those with HDP, but among those without HDP, they had a higher risk of SMM. So we can't consider all women equally. There are actually differences by race and ethnicity. And then lastly, we saw that greater county poverty as measured by county Medicaid enrollment was associated with increased risk of SMM, but that was in women without HDP diagnosis only. So we've seen there's disparities. We've seen factors that are contributing to HDP and SMM and their rise. That's a lot of information. And you guys came to the talk maybe because you want to know about the public health strategies. So I want to go through a few examples of public health strategies that are being worked out in Alabama and some across the country that are targeting this particular outcome. And I'm going to put this framework up here just to guide our discussion of some of these strategies, because I think it's helpful for understanding the multiple systems levels at which we can intervene on a complex issue like hypertensive disorders or pregnancy. So the 4 rectangles you see encapsulating the flow diagram are important to note. Policy at the top, then structure, then process, and finally outcomes at the bottom rectangle. Interventions can be designed at each of these levels to improve the effectiveness, efficiency, and or the equity of the components of the flow diagram, as indicated in the health services research box on the right. So those are the ways that we examine the interventions at the policy, the structure, the process, or the outcomes level. So I'm going to walk through specifically examples of how we're intervening at these 4 levels in Alabama and some examples nationwide. And so we'll start at the policy level. So Medicaid expansion is the first example here. Earlier, we reviewed the 5 categories by which women become eligible for Medicaid in Alabama, which again ensures over 60% of births in our state. Over half of those Medicaid births are actually through sober coverage, which again is only eligible for women who are already pregnant. So the Affordable Care Act, passed in 2010, offered generous funding for states to expand Medicaid to reach more people. And they were going to do so at a higher federal match rate of 90%, which is much higher than our current match rate in Alabama of 72%, which is still pretty generous. In a report from the Public Affairs Research Council of Alabama recently, in 2022 actually, they estimated that cost savings for the state, were we to expand Medicaid, for pregnant women alone would be $30 to $40 million a year. And this was work that was done in part by David Becker at the School of Public Health at UAB. So we see that there are cost savings to Medicaid expansion as a policy intervention in Alabama. But more importantly than these cost savings, this expansion would enable many more women of reproductive age to have access to healthcare coverage. Since much of the burden of HTP begins even before conception, this could have an immense impact on HTP in Alabama. Next, let's turn our attention to some interventions at the structure level, which influences factors of the delivery system, the population at risk, and the environment. One example is something very interesting that Alabama Medicaid has been doing to make their current funding stretch further to meet women's needs in our state. So through a 1915B waiver for the Centers for Medicare and Medicaid Services, Alabama Medicaid established what they call the Alabama Coordinated Health Networks, or ACHNs, in 2019. So these groups have quality goals that exist for child health and mental health, as well as maternal and infant health, and they're focused on producing better birth outcomes. Now, although insurance coverage through Medicaid expansion is not a reality for many Alabamians, the ACHN program combines case management for family planning, maternity care, and primary care to improve the continuity of care for women who are pregnant, especially for those at high risk, like women with HDP. Additionally, each network has quality improvement goals that are focusing on specific morbidities that affect pregnant women in their region. And I worked with some of these regions during graduate school, and they're thinking very creatively about how they can reach women in their areas and improve the health and outcome of their pregnancy. It's a very cool, a cool project that Medicaid is doing. Another entity in Alabama that's a structure level entity is the Alabama Perinatal Quality Collaborative. And some of the ALPQC folks are on the meeting, so thanks for your attendance. So this began in 2018 as an outgrowth of something called the Alabama Perinatal Excellence Collaborative. But PQCs exist in most states, actually, and they're multidisciplinary teams that work to improve maternal and infant health by advancing clinical processes, and they use quality improvement principles. Importantly, though, they serve as a platform for collaboration between academics, public health, insurers, hospitals, patient advocacy groups, and many other entities that are all working to improve maternal and child health. In addition to this important structural role of PQCs, they also conduct statewide QI initiatives, quality improvement initiatives, to improve health outcomes. Specifically, the ALPQC has been successful in launching 3 initiatives: the Birth Certificate Accuracy Initiative, the Maternal Hypertension Initiative, and the Neonatal Opioid Withdrawal Syndrome Initiative. As we look back at our framework, let's zoom in on some process interventions which affect things like realized access to care and health risks of individuals. And one process intervention is actually one of those projects by the ALPQC. And they've been conducting this project around maternal hypertension. So they're using evidence-based protocols to improve the management of severe hypertension in pregnancy, which is a main driver of severe maternal morbidities, as we've already established. So this project is a part of a national consortium called the Alliance for Innovation on Maternal Health, or AIM. And the ALPQC is also using the Institute for Healthcare Improvement's Breakthrough Series, which is an evidence-based quality framework that has had a lot of success in other areas of public health. So hospital teams participate voluntarily across the state to implement quality bundles, and there's monthly calls and meetings to share ideas for improvement in their own facilities. So there's great cross collaboration across the state. I just want to give a shout out to Evelyn Coronado-Guillame, Dr. Brian Bricado, and to all the hospital teams staying committed to this ALPQC project, because it's been hard through COVID. There's been a lot of other things going on. Another process level intervention happening in our state is actually through the Department of Public Health, the Child Health Insurance Program, and the Blue Cross Blue Shield of Alabama, kind of a collaboration between all 3. It's called All Babies. This is a pilot project targeted at women who don't meet those Medicaid qualifications income-wise, but they also don't have comprehensive health insurance. The program is currently operating in 3 counties, Macon, Montgomery, and Russell, and pregnant women in these counties experience an undue burden of morbidity compared to other counties in the state. So this intervention is really trying to improve the health of those women who are pregnant in those areas. And this program ties together multiple avenues of care, including mental health and substance abuse services, which, as we saw earlier, are really big drivers of maternal morbidity in Alabama. So again, All Babies, another great thing going on in Alabama to address this problem. So lastly, let's take a look at some interventions at the outcomes level, which include factors that can directly mitigate adverse outcomes to improve health and well-being. So first, we're going to look at blood pressure measurement validation. Both the American College of Obstetricians and Gynecologists and the American Heart Association endorse using at-home blood pressure devices for women with HDP, especially when it's uncontrolled. Device validation guidelines, however, recommend that any device on the market should be validated separately in pregnant women due to physiological changes that occur that could affect the readings of some devices. So I've been working on a project with Doctors Rachel Sinke and Ayamo Oben in UAB Maternal Fetal Medicine Division, along with their team, which includes Vicki Bright, who introduced me before this talk. Our aim in this project is to validate a unique device. It's called the Ideal Life BP Manager, and it actually transmits a patient's blood pressure directly to their medical record without internet. This can be especially important in rural counties in Alabama with limited internet access, which are also the counties that tend to be burdened by HDP. And you can see a map of where the internet access is the least, which is that dark red. And this figure just shows the device, a picture of the device. So that's one cool outcome-oriented intervention that we're currently doing research on. Another thing is something that I'm really excited about, and I'm calling it an outcome intervention. It could be one day, but it's really the results of this randomized control trial called the CHAP trial, which stands for Chronic Hypertension and Pregnancy. So this was published just this month, actually, in the New England Journal of Medicine. Dr. Alan Tita at UAB led this 6-year multi-site study with 70 centers. And it also included Dr. Susan Baker's group at the University of South Alabama, for those who know her. Their goal was to investigate the treatment of mild chronic hypertension through pregnancy instead of just treating high-range hypertension, which is kind of the current gold standard in the US. So after enrolling over 2,400 women with mild chronic hypertension, they found that actively treating chronic hypertension throughout pregnancy to control blood pressure below the threshold of 140/90 improved several outcomes compared to the gold standard or the standard treatment of withholding treatment until blood pressures reach 160/105. So their primary composite outcome included preeclampsia with severe features, preterm birth, placental abruption, or fetal or neonatal death. So it was any of those outcomes that we're looking at as kind of this composite outcome. And they found that the risk of these things in aggregate was reduced by 18%, an adjusted risk ratio of 0.82 in the active treatment group compared to the withheld treatment group. And the risk of preeclampsia and preterm birth similarly were reduced in the active treatment group. And another important finding of this very large prospective study showed that the small for gestational age birth weight was not different in the two groups, which is a positive since up to now, it's been theorized that having antihypertensive medications during pregnancy could affect the growth of an infant in utero. And that's been shown in other smaller trials. So this result in particular is interesting. So the implications of this trial could be pretty great. Other countries and international societies already recommend the treatment of HDP at lower thresholds than we do in the US at 160/105. So this trial could support a change of recommendations in the US, at least among women with chronic hypertension. And I want to stress that this would be especially impactful in Alabama since our burden of not just HDP, but also chronic hypertension is really high, especially for women comprising minority and low-income populations, as we've seen through some of the research that I discussed earlier. Whew, I bet you guys are tired. I sure am. So we kind of are at the end of what I have to present. So just in review, we discussed some important definitions for HDP. We examined some epidemiologic trends for HDP and related outcomes like SMM and maternal mortality. We took a closer look at the case of HDP in Alabama, and we reviewed public health strategies at several systems levels that are currently being used to address HDP both in Alabama and nationwide. So if nothing else, I know there's a lot of numbers and a lot of terms. I hope that you've gained, or I hope that you've gleaned from this talk, both the significance and the complexity of HDP. And I hope that you also realize that there's a lot of great work going on to improve the health of women experiencing HDP, both in Alabama and nationally. And that is certainly a worthy cause. So with that, I will open up the virtual floor for questions. The question is, there's an association that we found between mental health conditions and having an HDP diagnosis. Can you basically speak more to that? What does that mean? Or what do you hypothesize that that means? So in that analysis, we were looking at mental health conditions kind of in aggregate, which is based on the ICM criteria for mental health. So we used a pretty broad catch-all term for any mental health condition, which includes substance use disorder. So since we know that that is often comorbid with other health conditions during pregnancy, that could be one possible reason why that's associated with an increase in HDP diagnosis. Also, the data that we use and the way that we use them could kind of bias our results towards women who use the healthcare system more. So there could be more association simply because women who have a mental health condition also are using the healthcare system, and they're more likely to be diagnosed with a hypertensive disorder of pregnancy, whereas women who don't have a mental health condition and maybe aren't seeking out treatment, or the opposite, women who have high blood pressure are going to come in and see their provider and get treated for it, get diagnosed. They're also more likely to undergo mental health screening for different conditions and then receive another diagnosis of mental health. The question that Vicky put in the chat, where does the ideal life blood pressure measuring system stand as far as being provided to moms? I know research practice is forever, but do you see this becoming available soon? Okay, that's a great question. So that's a whole nother talk, the gap between research being conducted and interventions actually entering the population. So this device specifically was on the market, but there was some anecdotal evidence from providers that it may not measure pressures in pregnant women accurately compared to other devices or a gold standard with a mercury sphygmomanometer. And so they actually took it off the market for those concerns, but it was never formally validated in a population of pregnant women. So that's why Dr. Rachel Sinke wanted to do a study. So there doesn't have to be a validation in pregnancy for a device to be put on the market. It has to be undergo other regulatory steps through the FDA, but not specifically in pregnancy. That's an additional step that a lot of researchers will do just to make sure that when using in pregnant women, that it's accurate in their bodies as well. Danielle asked a question about preeclampsia. Do we see ways to better treat preeclampsia, especially with her experience at UAB of women suffering from preeclampsia and having some severe outcomes, and kind of the current treatment mainstay is delivery. And that really is kind of the current mainstay. Preeclampsia is not necessarily kind of one, there's not one pathway to preeclampsia. And actually the pathophysiology, how preeclampsia develops, is still not well understood. There's different theories. And so the best thing to do is actually prevent high range blood pressures and prevent elevation of those blood pressures, which can progress to preeclampsia. I can't speak to treatment options with preeclampsia specifically, but I do know the CHAP trial, which has been being conducted at UAB, showed some really interesting results that it reduced preeclampsia. So it shows that antihypertensive medications are not harmful to the fetus, at least with the outcomes that they were looking at, and also can reduce the risk of preeclampsia. So that's really exciting if we start to use those medications more broadly and women experience moderate elevations in blood pressure. I think there was another question from Julia in the chat. Julia says, do you see the racial disparities in this topic being due to racism, biological factors, or something else? That's a great question. So in the analyses that we did specifically, and this is borne out in other research as well, we control for a lot of factors. Now, we don't control for everything. And basically what that means, what we control for is essentially we try to take out of our models other factors that could be contributing to the outcome, SMM or HDP in the data that we did. And even after controlling for all of that, we still saw differences among Black women, among Hispanic women. And so there's not evidence in our data, but other data to show that things like implicit bias, discrimination, and racism could be at play in some of these differences. And that is a whole area of study in and of itself, what drives those things with some groups of women. But the short answer is it's more than just biological factors. It's kind of a mixture of a lot of factors. Who else has a question? Anyone else?
Okay, I do. I guess it's kind of based. Can you hear me clearly now, Liv?
Yes, I can hear you.
Okay. Okay. So when you were talking about like the disparities, like certain counties that had higher rates of, hypertensive disorders, you mentioned Macon, Montgomery, and Russell. I guess it's kind of building on Julia's question. Was there a common theme there, or, why those counties, why did they have such a need?
Yes. So there's a region in Alabama called the Black Belt, which is traditionally named that due to the richness of the soil. It's kind of a intensely agricultural region that runs through kind of the middle ribbon of the state, including Montgomery, Selma, all the way over kind of to Georgia. And that's where those counties lie for that particular project. But because of historical reasons, a lot of African Americans reside in those areas because that's where slavery, was prominent, in particular in Alabama. And so those people, the same populations kind of resided there, but because of the same historical reasons, there are areas that are that experience an undue burden of poverty, which I think certainly affects health outcomes. And so I guess as alluded to by Julia's question, it's kind of a mixture of factors. And I think that's why ADPH decided to start with some of those counties, because there's the greatest need and greatest room for improvement there. And that's a pilot project. I don't really know the direction of that. I know some people at UAB School of Public Health are kind of monitoring that and evaluating to see about possibly expanding the program, because it results in cost savings, and above and beyond that, it results in better outcomes for women.
Matthew Ron Hagen. I'm an MPH student, but I'm a retired ER doctor.
Hey there.
Are you planning on going to OBGYN?
So the question was, am I planning on going into OBGYN? And I think that's yet to be determined. I just finished my second year of medical school, and I'm starting clinicals in May. So that'll be my introduction into each specialty on the ground. So I think I'll have better information a year from now. But I haven't, it's certainly on the list of options.
In the ER through the years, we saw mostly postpartum hypertension, but occasionally the HELP syndrome people, but occasionally we would see an unknown pregnancy roll in the door with preeclampsia for sure, and sometimes even eclampsia. And the pregnancy was a mystery until somebody put their head on straight. So good luck in your pursuit. It's a wonderful presentation, and I wish you the best.
Well, thank you very much. I appreciate that. And that's actually an important thing, that emergency departments are a big part of this project that ALPQC is doing statewide, because in rural areas in particular, when women present at the hospital, there's no specialized obstetric emergency area. They just present to the ER, even for labor and delivery. Oftentimes the hospital doesn't even have obstetrics department, so they present to the ER for delivery. And those cases, as you just alluded to, can present differently. So that's one area where the PQC is trying to partner with ERs to improve surveillance for those severe range hypertension. Thank you everybody for attending today. I know 5 p.m. is kind of a rough hour, but hopefully you did learn something, and hopefully you can be an advocate in the future for pregnant women in Alabama and nationwide, because it's an important thing.